So good morning. So any evidence for mechanical CPR? By way of conflicts of interest, I've received research funding from the National Institute for Health Research, which is the UK funding arm for research in our National Health Service. I also have various roles with the European Resuscitation Council, ILFOR and the Journal of Resuscitation. What I thought I'd run through over the course of the next 15 minutes are these 5 points. Firstly, to have a look at the rationale that led to the creation of mechanical CPR devices, to then look at the evidence that has come out particularly recently with respect to the effectiveness of mechanical devices for cardiac arrest, and then to actually start to look at some of the detail around when they might be considered, and if you are going to consider them, what's the optimal way to deploy them and what to look out for potentially after the use of mechanical CPR. So the foundation or the concept behind mechanical CPR has really come to light, or at least the evidence has come to light recently around the importance of high quality CPR. And as you can see in the slide here, chest compression depth and optimal depth of between 4 and 5 centimetres, with deeper chest compressions in the right hand side, showing that deeper chest compressions are better than shallower chest compressions. Similarly, making sure that those chest compressions are maintained at a standard rate with a sweet spot between 100 and 120 beats per minute, providing you an optimal chest compression rate. And then finally, keeping the compressions going and minimising interruptions in chest compressions. And that's important not through the whole resuscitation account, but particularly around the time of delivering a shock to a patient. But of course, undertaking and maintaining high quality CPR is physically demanding and something that professional and lay rescuers indeed struggle with. And as you can see on the left hand side there, one of any series of studies showing that as time progresses, the ability of a human to maintain high quality CPR diminishes. Over on the right hand side, you can see that can be slightly mitigated by an elegant study that looked at the rescuer changing at the point that they start to feel tired, as opposed to changing on a 2-minute basis. But nevertheless, clear evidence that the man undertaking CPR leads to a reduction in quality over time. So really the background or the concept behind mechanical CPR is it's something that could be automated, and all of these machines here produce or deliver high quality, uninterrupted CPR to specific specifications that have been set by the device. So intuitively, mechanical chest compression devices, if you look at the observational data, informing them should improve outcomes. I'm going to walk you through the 4 studies or the 4 large randomised controlled trials that have evaluated mechanical chest compression devices to date. 2 have focused on the AutoPulse device and 2 have focused on the Lucas device. So over on the left-hand side of the slide, the Aspire trial was a US-Canadian efficacy trial conducted just over 10 years ago now, and it randomised just over 1,000 patients to mechanical or manual CPR, the primary outcome of 4 hours. The CIRC trial, a more recent trial, an individual patient randomised trial, randomised just over 4,000 patients with the primary outcome of survival to hospital discharge. The LINK trial, a study evaluating the Lucas mechanical chest compression device, randomised 2,500 patients with a primary outcome of 4 hours survival. And then our own paramedic trial, which was an effectiveness trial. It was conducted as a cluster randomised trial, and it was the only independently non-industry funded trial, and our primary outcome was 30-day survival. We've pulled together the results from those 4 randomised controlled trials in this meta-analysis that's conducted by my colleague Simon Gates. And as you can see on the top of this slide, the point estimate for survival or to discharge or survival to 30 days, there's no significant difference between the mechanical and the manual CPR for the Lucas device. And similarly for the AutoPulse device, if you look at the bottom of the slide there, point estimate on the side of favouring manual CPR, but no overall difference. Looking at survival and neurological function, again, no significant differences, although the point estimates tending towards favouring manual CPR. So the International Liaison Committee for Resuscitation reviewed this evidence and observational studies that run alongside or that have been presented alongside, and came to the conclusion that they suggest against the routine use of automated mechanical chest compression devices to replace manual chest compressions as a weak recommendation with a moderate quality of evidence. But ILCOR recognised that there are specific situations where mechanical CPR devices are indeed essential, and they suggest that the devices may be a reasonable alternative to high-quality manual chest compressions in situations where sustained high-quality manual chest compressions are impractical or will compromise rescuer safety. And I guess I'm just going to walk you through a few slides now, giving some examples of where it's impractical or at least very challenging to undertake manual CPR. And so moving a patient down a flight of stairs is logistically difficult or impossible to continue with high quality manual CPR, but it's possible to maintain CPR with the use of a mechanical device. CPR during ambulance transport, there have been a large number of studies that have shown that the quality of CPR reduces during ambulance transport, and as you can see over on the right hand side, the reality is when an ambulance is moving at high speed and going around corners, it's very difficult to deliver and to maintain high quality CPR, and as Dries Vollerskebenden showed, the CPR fraction is significantly reduced, but that can be mitigated through the use of a mechanical chest compression device. There's also the safety aspect of undertaking unrestrained manual CPR in the back of an ambulance, and although ambulance incidents and crashes are not particularly frequent, they nevertheless place the unrestrained ambulance technician or ambulance paramedic at significant risk in the event that the vehicle is involved in an accident. So taking a look at the European Resuscitation Council's Universal Treatment Algorithm, or Advanced Life Support Treatment Algorithm, I'll try to give some insights around where the use of a mechanical chest compression device potentially can be considered, and I'll address firstly shockable rhythms, and then I'll have a little look at non-shockable rhythms. And I think a key part of this is based around what's the specific indication, what is the reason that you're wanting to transport a patient into hospital. And we heard in yesterday's talk from Hans Freiberg that there are universal termination of resuscitation rules that were developed by Laurie Morrison, but there are specific indications or specific scenarios where you may want to transmit or transport a patient into hospital. So starting off by just briefly considering patients that have a shockable initial rhythm, my personal view is that at the start of the resuscitation attempt, it should be early, high-quality manual CPR whilst the defibrillator and equipment are assembled and an early shock is given to the patient. Indeed, when we looked at the Lucas mechanical in our paramedic trial in patients with shockable rhythms, there was actually a significant reduction in survival to discharge in patients that received the autopulse as opposed to receive manual CPR, and we've hypothesised that that's likely to be due to the interruptions in chest compressions that you get around the time of device deployment, and how that's particularly critical in patients with shockable rhythms. So my practice and my advice is that in the event that you have a patient with an initially shockable rhythm, that you would stay on scene at least until you've delivered the first 3 shocks before then making a decision on your pathways whether you're going to take a patient into hospital. And of course, the only reason or the only point of taking a patient into hospital in a shockable rhythm is if the hospital is going to offer anything greater than you're able to provide at the roadside, and that will very much depend on the system configuration and the capabilities of the hospital. Interestingly, data from both the autopulse and the Lucas device, the autopulse device, these were human data published last year, that you can see that actually shock successes or termination of fibrillation is greater in the manual CPR sequence than during the compression phase with your pulse device. So again, these data seem to suggest that one should briefly pause the mechanical chest compression device whilst delivering defibrillation, or at least there's certainly no evidence to compel you to deliver a shock in synchrony with mechanical CPR. So I talked about patients with shockable rhythms and the need to transition into hospital, and I think a bridge to PCI, again, we don't have strong data saying that a patient that remains in cardiac arrest benefits. We can't say that with certainty for going to the catheter lab, but if it's a consideration and an approach that your system have, then a mechanical chest compression device becomes essential, both in terms of the transport to hospital, but also to allow the procedure to be performed. They can also facilitate diagnostic imaging, and again that can be helpful, particularly if you're starting to think about eCPR, about potentially prolonging a patient's time during the resuscitation phase, that you may want to rule out irreversible causes of death, such as a massive intercerebral bleed. There's also a series of case studies, and again, we're not ever going to have randomised controlled trials that say we should be using mechanical chest compression devices, but there are some things that are intuitive and make sense, where you're needing to undertake prolonged CPR, as may be the case with hypothermia, drowning, pulmonary embolus, or electrolyte disturbance.